Thank you, Mark. I'm just going to share my screen real quickly. Can you all see my slides?
Yes.
Yeah. So today we're going to be discussing the ethical challenges of effective pain management in patients with severe cancer pain and substance use disorder. This is something that we encounter frequently as clinicians here in Baltimore and likely throughout the United States and throughout the world. So I want to start by first introducing this great multidisciplinary group of panelists. I'm going to have them each tell me their name, their background, their role here at Hopkins, and please let us know if you have any relevant disclosures that the audience should know. So we'll start with Ms. Lynn Billing. Lynn.
Hi, I'm currently a palliative care nurse in the oncology setting. I've been at Hopkins since 1999, working in various roles, pain management, palliative medicine in the oncology center. I was also a member of the ethics committee for 13, 14 years.
Thank you, Lynn. We'll go on to Dr. Patrick Carroll.
Hi, I'm Pat Carroll. I'm the Director of Psychiatric Services at the Sickle Cell Center for Adults here at Hopkins. I'm a psychiatrist, and I've worked with people with chronic pain and addictions in all manner of capacities in the last 15 years.
Thank you, Dr. Carroll. Next is Ms. Carla Jackson.
Hi, I'm Carla Jackson, and I am a social worker on the palliative medicine team here at the hospital, and I see patients in-house as well as in our outpatient palliative clinic. I've been in palliative care for probably the last 12 years. Prior to that, I worked in hospice. And actually at the beginning of my career, I worked in psychiatry here with substance use disorder at that time.
Thank you, Carla. Next, we have Dr. Travis Reeder.
Hi, I'm a research scholar and director of the Master of Bioethics degree program at the Berman Institute of Bioethics here at Johns Hopkins. And I have a disclosure to make, which is that I have stock in AstraZeneca because my partner used to work there. I do not believe that any of their products present a conflict for these purposes. I also have written a book that is on the subject of pain and opioids, and I received royalties from the sale of that book from HarperCollins.
Thank you, Travis. Next, we have Dr. Julie Weldfogel.
Hi, I am a pharmacist and clinical pharmacy specialist. My specialty area is pain management and palliative care, and I work primarily with the palliative medicine service, but do some clinical time with pain management and acute pain management services as well.
Thank you, Julie. And I'm Lauren Berninger. I'm one of the clinical fellows here at Hopkins in hospice and palliative medicine. So these are our objectives, which you may or may not have read before we started the presentation today. But here we're going to discuss these ethical challenges in managing cancer pain in patients with substance use disorder. We're going to look at the possible tension between the principles of beneficence and non-maleficence in treating cancer pain in patients with substance use disorder. We may look at how social factors and implicit bias could potentially influence prescribing practices. We'll look at the varying duties of clinicians to patients and duties to public health when prescribing opiates in the midst of an opioid epidemic. And then we'll discuss practical approaches to managing pain in these patients from both an addiction medicine perspective and a palliative medicine perspective. And furthermore, we're going to explore the role of the palliative medicine interdisciplinary team in addressing the comprehensive needs of patients with cancer pain and substance use disorder. So I just want to give a quick overview of the scope of the problem. So there really has not been a ton of literature to date on the incidence of substance use disorder in cancer patients. There was a systematic review out of Dana-Farber in 2019 of substance use in cancer, and it found that the rates of substance use disorder were up to 35% in cancer patients with a median opioid use rate of about 18%. The studies that there was a lot of variability between the studies that they looked at, and the range was from 2 to 35%. There was an observational cohort study of men with advanced prostate cancer in 2018 that revealed substance use disorder's prevalence of 10.8%. These were in Medicare enrollees. And then there was a cross-sectional study of over 480,000 veterans with cancer that found that 6.64% or 32,000 had comorbid substance use disorder. So there's a considerable minority of patients who have both substance use disorder and cancer. So why does this matter? So patients with cancer and substance use disorder have very highly complex needs. So they have increased psychiatric comorbidities, increased medical comorbidities, including hepatic disease, largely owing to hepatitis B, hepatitis C, and alcoholic liver disease. There's an increased risk of homelessness in these patients, and increased use of the healthcare system, inpatient visits, outpatient visits, ER visits. There's a higher use of prescription opiates in these patients in general. And unfortunately, there's less desirable outcomes, including some research to suggest that there's decreased survival in these patients. And lastly, and very importantly, there's a potential for undertreated cancer pain for a variety of reasons, which we'll likely discuss during this talk today. So adding to the complexity, here we are in the midst of the opioid epidemic, as if COVID were not enough. And we've seen rising death rates from opioid-related overdoses from 1999 to 2017, with over 450,000 opioid-related deaths until 2019. So because of this, there's been increased pressure on prescribers to restrict their opioid prescribing. There's increased surveillance, including new monitoring programs like the PDMP program. And also we've seen drug manufacturing shortages, especially with IV opioids. So we know that treating cancer pain often relies on opiates for moderate to severe cancer pain, and they can be highly effective when they are prescribed appropriately. But at the same time, we want to be responsible in our prescribing and yet compassionate and safe in the care of our patients. So that brings us to a case. So here we have the case of Mr. O. He's a 48-year-old African-American man with a history of stage 4 non-small cell lung cancer with extensive bony metastasis that's been refractory to treatment. He has active substance use disorder and intermittent homelessness. He's admitted to the hospital for treatment of pneumonia following his most recent cycle of chemotherapy. While his condition improved with intravenous antibiotics, his hospital course has been complicated by intolerable pain in the setting of bone metastasis and chemotherapy-induced peripheral neuropathy. Despite his stated pain levels, his medical team has been reluctant to continue escalation of opioid therapy. Following previous hospital discharges, the patient has been known to use fentanyl, heroin, and cocaine when his prescribed opioids have run out. He reports difficulty finding outpatient providers willing to provide adequate pain control for cancer, given his history of substance use disorder and frequently missed appointments. Palliative medicine is consulted for assistance with this patient's pain management. He has received palliative radiation and is also receiving all appropriate adjuvant non-opioid medications, but he reports severe worsening pain. Palliative medicine consultants recommend increasing his current doses of opioid medications while he is an inpatient to improve his overall pain control during this pain crisis. They further recommend that once his acute pain crisis resolves, we carefully come up with an appropriate discharge regimen for him. And I'll go on to say that this patient's prognosis is approximately 3 to 6 months at best. So with that being said, I'm going to turn this over to Dr. Travis Reeder to talk about the ethical issues he sees with this case from the perspective of a bioethicist and moral philosopher. Travis?
Thanks, Lauren. I think that it's probably unambiguous to all of us that this is a really challenging case. It's a challenging case that's relatively common for a lot of the physicians who work with this population. I want to do something very high level in like 3 or 4 minutes. I will not provide a concrete recommendation. I'll leave it to the folks who do the clinical work to start weighing in on that. But I'm going to give something like a framework that I use when I teach clinicians about ethics and pain management. And it's not that the framework is going to do anything revolutionary, but I hope it helps us hold a bunch of competing moral considerations in our head at the same time. So in the setup, Lauren mentioned, that there is both considerations of beneficence and non-maleficence. One of the ways that I think about this with reference to pain management is that we have reasons to use opioids to treat various sorts of pain, and we have reasons not to use them at the same time. And so really common instance of that duality is that opioids might be really powerful analgesics for a particular pain, like this patient's cancer pain, but it comes with risks. And some of the most obvious risks, especially living in America right now, are risks of addiction, substance use disorder, overdose, and death caused by overdose, death caused by overdose. So these are really severe risks. They're certainly not the only instances that are going to raise non-maleficence. So opioids also just have other side effects that are particularly unpleasant, but these are the ones that are really kind of out in the forefront of today's conversation. So now you put it in the context of this patient who has active substance use disorder, and the risks become very live. So one thing that I want to do is I want to say from the get-go, when there is a live risk that a harm comes to pass, that doesn't undermine the existence of the competing reason to, say, alleviate pain. So this patient seems to be in very severe pain. There's reason to think that opioids would help his pain. And the fact of risk, given his history of substance use disorder, doesn't make that go away, it just complicates it, which means we're in this really difficult situation where the reasons have to be kind of considered altogether. Now we're gonna add one more really complicating feature, which is in medicine today, we largely, clinicians, but people in society who are doing non-prescriptive work as well, we don't respond to all patients in the same way. And so we respond differentially to patients based on their race and their gender in particular. So it's of note here that this patient is an African-American man. So here's what we have good empirical data on. We take African-Americans' pain less seriously when it's reported. And as a result, we treat with opioids less aggressively. There's really compelling data on all of this, as well as the causal link between the two. And so it's not that we have these competing reasons and that makes it hard already. It's not that we undertreat and overtreat with opioids kind of in a mishmash of ways, although sometimes we do. It's that we also do it in systematic ways where African Americans are systematically treated less aggressively with opioids, and white men in particular are treated more aggressively with opioids. So we have this issue of respect, dignity, justice that has to go into the hopper as we think about the ways in which we're balancing. And so I, in particular, am going to be very concerned that the clinicians are not responding to non-clinical features of the case. So that because he's an African-American man, he's being treated with more suspicion and less likely to be treated with opioids. All right, so the last thing that I'll say is that's a setup of the challenges just involved in whether or not to prescribe opioids. That question gets all of the play when it comes to the clinical case of dealing with pain management and opioids. It's like, should I write this prescription? That's the way the ethics question is framed. But note that the answer is very often going to be yes. The patient needs opioids in the moment. And so what's really important to note is that there are more criteria for responsible pain management other than whether or not you should write the prescription at this moment. And so in particular, to be a responsible prescriber of substances like opioids, you have to have appropriate management of that patient while they're on the medication. And if it's appropriate, if they are eventually expected to be off the medication, there has to be appropriate deprescribing. And so one of the slogans that I give every time I give talks on this subject is responsible prescribing entails knowing how and when to appropriately deprescribe, right? This is part of the whole, it's a package deal. So a toxicologist in Canada who I've worked with a little bit at a distance, he gives a talk on this issue and he says, don't fly a plane unless you know how to land, right? That's part of the package deal. In this case, what that means is, it sounds to me, I'm not going to make a recommendation, but it sounds to me like in the acute sense, opioids are probably a really responsible choice, but that doesn't mean you prescribe and forget, right? A big part of the issue with this particular patient is knowing how and when follow-up will be appropriate, possible, how successful, et cetera. So follow-up, deprescribing if appropriate, making sure that there are various wraparound services available. So that's a lot. And hopefully people see that even at the highest level of kind of what moral considerations are at play, ethics of pain medicine is very complex, not just beneficence and non-maleficence, beneficence and non-maleficence in the context of justice, and then requirements to do the long-term hard work of management and deprescribing as well.
Thank you, Travis. I'm going to turn it over now to Ms. Lynn Billing to give a little bit of her perspective on this case as a nurse in palliative medicine and on her experiences with similar patients in the past.
So over the years, we've seen many, many patients like this gentleman. And like Travis said, this gentleman is in need of opioids because of his disease. Number one, he has pain. The pain is likely to get worse because he's gotten all the treatment that we know to give to help his cancer and help his cancer pain. He's on multiple adjuvants. They've tried everything else they could think of, and we're kind of stuck with opioids for this gentleman. So we know he's been out on the street using drugs. There's a million questions I want to ask him, why, but mostly I need to know about his pain. And I think that's something that we as clinicians kind of overlook a little bit because we're so focused on the opioids and not doing harm, but doing good and trying to figure all that out. But we need to understand his pain. Just to give you an example, I've seen patients talking about their pain, and I say, where is it? It's all over, it's all over, it's all over. And, you know, when is it worse? I don't know. And to keep asking questions and to finally find out, you know what, this pain is this, it gets worse when my husband's here and he's telling me I shouldn't take opioids. And that's when I feel terrible. So it's not just physical pain, but in most cases that I deal with, it is physical pain. I just wanted to throw that part in there. This is really difficult, and it takes a village to take care of these people. It's one of the palliative care physicians at MD Anderson says you need to take a posse with you to see patients like this. There's a lot of ways we can do harm. I kind of feel like I'm the person that wants to do good, and I'm focusing on that. But the ways that we can do harm, I think it's not only giving too many opioids so they can overdose, but there are other ways we can harm patients. And I just want to share two brief stories. One story. I had a patient very early in my career here who was an addictions counselor, and he was going through treatment for head and neck cancer. That treatment included 7 weeks of radiation, so that's 35 radiation treatments to his neck, this area, along with chemotherapy. And that's pretty brutal regimen, and we know he had pain to begin with, and this regimen causes a lot more pain. So talked about what we thought would help him, and he had trouble swallowing. So we ended up giving him liquid oxycodone. And he was doing fine for a while, and he was probably halfway into his treatment. And he came in one Friday evening and said, "Lynn, I'm in trouble." And I said, what's going on? How's your pain? My pain's fine, but I'm going down to President Street to get more. And so this addictions counselor that had been clean for 10 years, by starting opiates for his pain, had to go get more pain medicine, as he told us, to treat his pain because we weren't giving him enough, number one, but also it kicked in his addiction again. And he was very open, saying, I can't control this. I don't know how to control it, and I need help. And he actually asked us to be admitted to the hospital that day. Just one other example of an ethical issue that Julie and I were involved in, and this was a young woman who was in a lot of pain. She was very close to the end of her life, and she was an inpatient at the time, and crying to us in pain with her. She was about 22 years old. Her father was at bedside, and he was crying to us that we were hurting her by giving her pain medication. And I know Julie remembers this one. This was really tough. And the daughter kind of said, I want to do what my dad says. I need to listen to my dad, because she didn't want him to feel as horrible as he was feeling and to add to his distress. So she actually opted to take less pain medication because of that. And she dealt with a higher level of pain to help her father's level of distress. So there's lots of angles here with doing good and not doing harm. So I will leave it at that.
Thank you, Lynn, for your perspective. I want to move on now to talk with Carla Jackson. She's one of the palliative social workers here. And Carla, I want to talk specifically about some of the social factors that come into play with these patients who come to us seeking treatment.
Thanks, Lauren. Yeah, when I read this case, I think of a lot of patients that we see in our palliative clinics. And, you know, the first thing that comes to mind are the support systems. That's always my first question to someone is, what supports do they have in their life? What is intact still? You know, unfortunately, substance use brings a lot of chaos into that person's life and perhaps into the lives of all the people around them who may love them very much. But families sometimes have to make some really hard decisions of how to distance and love from a distance. But now that we're talking about someone that is in the throes of substance use as well as an advanced cancer, and I'm going to talk about that too. You mentioned the prognosis, that's significant here. You know, does he have anyone that he connects to still? Is there anything in his life still meaningful that we can tap into and try to build upon that with him? The lack of housing, you know, it's just a snowball effect. When you're lost in the throes of chaos, you know, you can't keep up with your housing, your medical care, your family, taking care of yourself. These are all the things that unfortunately fall by the wayside. So those are things that we're trying to help that person sort through in addition to their cancer. In Prognosis, we seem to get people in pretty late stages of cancer when they have substance use disorder. You know, we could easily follow a patient for years in palliative clinics, but for some reason, by the time they make their way to our clinic or our team, they're pretty advanced in cancer. And so we're looking at it in a different lens as well. We're looking at, you know, if we're approaching end phase of illness here, we need to be having a lot of other conversations with that person as well. They're probably appropriate for hospice care. And I don't know why there's such a delay in us seeing them. I don't, perhaps they're diagnosed in a late stage. That certainly poses a problem for everybody. I don't know if it's a lack of access to care, if it's just avoidance of health systems because of the stigma. You know, people who are lost in substance use, they feel a stigma. They know there's a stigma. They don't want to seek out attention in healthcare systems. They don't want to bring any more attention to it than what's already there. Maybe their earlier symptoms were masked because they were using, and it kind of took care of their pain management needs at that time, or whatever the symptoms were. And their coping skills are limited. So, you know, there's just lots of reasons, I guess, why that happens. But the different lenses that I look at this case, certainly, you know, when I was working in substance use, there's always that hope for recovery. There's always that hope for connecting back to people who are meaningful in your life and trying to make amends if you can. And a life well lived is a person in recovery, you know, from a substance use angle, feeling good about making those changes and just really working hard on their recovery the rest of their life. So I fully respect the power of addiction. Like Lynn, I've had people who have been in recovery for decades, and then they needed a surgery and they got pain medicine, and all of a sudden they're lost again. And so it happens that quickly. So full on respect for it. But I also have the lens now of a palliative social worker in this case. And as time is getting shorter, I'm feeling the sense of urgency. We need to really try to figure out some supports and help this person in all aspects, beyond pain management. What are the priorities at this point? And how can we address the other types of pain besides, the cancer pain? Is the being marginalized, the loss of supports, and probably a lot of losses this person's had in his life. I don't know if that addressed what you were asking, but.
Thank you, Carla. Thank you for that perspective. So knowing everything that we know now, I want to talk a little bit about the complexities that come with treating cancer pain in patients with substance use disorder and what options are kind of available to them to reduce risk while providing effective pain management. So I want to turn it over to Julie and Pat to kind of discuss this a little bit further.
You want to talk a little, Julie and me, or should I go and you, or what you want to do?
Sure. I think I'm happy to start. I think we're both interested in kind of having a conversation together because we're dealing with kind of, as Travis said, we're kind of dealing with two illnesses at once here to try and kind of that are going to have to feed each other, and as we think about risks and benefits. A couple initial thoughts I have about treatment, specifically thinking about his pain management. Similar in that I think, as Lynn and Carla said, I have a lot of questions in terms of figuring out what next steps are. But we mentioned a couple things in the case. So we mentioned that he's on all appropriate adjuvant non-opioids. By that, we mean we can run a gamut of things from Tylenol and ibuprofen to like nerve aid medications and things like that. And it sounds like he does have a nerve component to his pain with his neuropathy from his chemotherapy on top of what sounds like bone pain from his cancer, which is great. And anybody, especially somebody with a complex cancer pain, we think of what's generally called multimodal analgesia, which is the concept of trying to treat pain because the pain is being generated by multiple mechanisms, trying to target the pain via multiple mechanisms to try and kind of mitigate or manage that. So that's wonderful to hear. I think one of the things that is important about that, one, the goal a lot of times about multimodal analgesia is certainly to better manage the pain, but sometimes depending on the pain we're talking about, we have some evidence that a multimodal approach can reduce their opioid requirements, which would certainly be positive. But depending on what non-adjuvants we're talking about, some of those non-adjuvants can increase your risk of side effects or overdose risk, depending on the opioid non-opioid we're talking about. So it's a balance to try to think about with that. I'm also curious to Carla's point, given we know he's intermittently homeless and what are his supports, in terms of that really important line at the end about figuring out what his discharge plan is going to be. Depending on how many multimodal agents we have on board, some of those are 3 times a day, some of them are multiple pills 3 times a day. His ability to pay for those things, if he's already missing appointments, how realistic is it for us to, how many medications is it realistic for us to think that it would be something he could manage and take care of at home, and what are the extra supports I can put around him to make that easier. Sometimes there are things we can do from discharging prescription point of view to make things easier, or what supports can I put around him in terms of other folks helping him with his medications or things like that. So I feel like in this scenario, Carla and I would be talking a lot about what we think is realistic support around medications that would help me know then what I could recommend to try to be helpful for his pain moving forward. And because I think medications are going to be complicated for his pain on multiple fronts, I'm very interested in things that don't involve medications that help him with his pain, especially things that are stuff that can be completed and not be something he has to continue to do. The case mentioned that we've already pursued palliative radiation in the past. I would be asking the same questions Lynn did, which is, well, where did we do that radiation? Is that where he's complaining about pain now? Because sometimes that we may not be able to do palliative radiation to certain spots, but if he's got new pain in new spots, maybe I can radiate that. And that is a definitive course of something, sometimes even just one single appointment that could provide some durable pain relief, especially for bone disease. We think about that. And then I think about our colleagues on anesthesia-based pain services, especially for cancer pain, because they can often give us some procedures or things like that to help blunt the response of nerves to certain pain signals, which also, depending on the procedure we're doing, can be relatively durable as well, on the kind of forecast of weeks to months, which is really what we're looking for in somebody who has his life expectancy. So I would be making sure we've exhausted all of those options as well, because if I can get that done while he's in the hospital and it's only the one appointment and he's already done it, then if I can provide him durable relief that way, then that would be something I'd be looking for. But clearly also part of the complexity, which I'll turn it over to Pat, is have to do with, addressing and treating his substance use disorder at the same time.
Well, that sounds easy, right? So I had a couple of thoughts about this case, and some of them are not exactly about this case, but they're more kind of big picture stuff that I think tends to come up when you're talking about addictions in general. And then some things are a little more sort of specific to this gentleman. One thing that I think is front and center in my mind is an idea about responsibility and autonomy. And where I think that really can play in with addictions is that we certainly want to respect people's autonomy and their decision-making ability, but I think you can kind of validly think about addiction as a disorder of the will. And it's precisely the capacity to make decisions that can be impaired around opioids. And so I think this kind of runs up against, we have, beneficence and non-maleficence, but we also are in a situation where I think, thinking in good faith, we can't necessarily rely on him to be making the best decisions for himself, given that he suffered from this particular condition either. So there's one thing. And then, when you're talking about pain and opioids and addiction all together, if you think about addiction as being a pattern of behavior that's kind of driven, reinforced by drug reward, if someone has pain, the drug will also relieve that pain. And so it's a negative reinforcer, and you can't see which it's doing. And so if someone has a pattern of behavior that's organized around opioids, you can't tell what they're doing, quote unquote, for pain, and what they're doing, quote unquote, because of the addiction. And I'm not even sure it's coherent to try. And so you can only see what they're doing, but you can't necessarily see why. And we can often get hung up, I think, in trying to see things that we can't see and make decisions based on it. And that gets really, really confusing. And then kind of more to his case, and I think I'm probably going to be singing a lot of amens to some of the things that Travis said. If we're trying to get him to receive opioid therapy for his pain that is, quote unquote, safe and effective, both of those things being very relative, then this pattern of behavior that he's engaged in probably isn't helping in either direction. I think we can talk a lot about the safety part of it, and I think that's easier to see. If he's using more than is prescribed plus using other drugs, and we don't know what they are and when, that's not a recipe for a lengthened life. On the other hand, I don't think this would pass for adequate management of pain or optimal management of pain with opioids either. And I'm not sure that being, missing his appointments and sort of having that kind of chaotic relationship with the medical care system is going to help either. So we have two conditions here, and one of them I think is interfering with both the safety and the effectiveness of treating the other one. And then I think, probably echoing a lot of what Carla said, addiction is its own kind of hellishness. It lays layers of suffering on top of anything else you're going through. And along with that, loads of isolation and shame. And so, one of the things that just jumped out of me, and granted, I've been an addiction doc for a while as well as a pain doc, reading this case was, I didn't see nearly enough about his history of treatment for addiction in this case. You know, a lot of the talk in here is about what's the way to use opioids to treat his pain. And I wanted to know so much more about what he was willing and able to do to try to get his addiction under control so we could do that. And going to Travis's point, you know, I think, Travis, you talk about it as, well, I can't, I'll let you speak for yourself, but, you know, one of the ways I tend to think about it is we also have a duty to know some stuff as clinicians, you know. So one is, if you're going to prescribe a drug that you know has a set of adverse events, you got to know how to detect and manage that, right? Or at least try. But also, you know, if you're prescribing the pathogen for another pathology the patient has, you ought to be able to know something about how to treat that pathology. And so I think one of the things we're missing here is we don't have a good evaluation of the guy's approach to and history with addiction treatment. And I'd dearly love to hear more about that. So those were my thoughts.
Thank you so much, Pat. So I think what we can take away from everyone speaking here today is that there is no one person who is going to fix this problem with a patient. It takes a team of professionals, addiction medicine professionals, specialized pharmacists, social workers, nurses, palliative medicine physicians, their primary oncologists. No one person is going to be able to fix this entire problem. So I'd like to kind of take some time to open this up to the audience to see if there are any questions. If not, we have some questions that we can ask the panel as well. So if anyone has any questions, if you could please put them in the chat box.
Lauren, I'm happy to queue some questions as they come up. Do you want to get us started?
Sure. So I want to bring up, there was an article written in 2017. It was an Australian paper by Pinkerton and Hardy, and it argues that patients at the end of life, effective pain control in these patients is paramount, and concerns around addiction are inappropriate. I was wondering if the panel could respond to that, or someone on the panel could respond to that.
Can I give just a formal response really quick? And
Yeah.
then I imagine that the docs have all sorts of responses.
Yeah.
It was tempting to even set this up in the beginning, right? So here's a formal argument for something like that conclusion using the framework that I set up, right? You've got all these moral considerations that are often in tension with one another. And then the job of hardworking folks trying to do the right thing in the mud of the actual real world is to try to plug in facts that help us mitigate some of the considerations, explain away some of them, and then we kind of see how it all shakes out, right? This is like a really messy scale going on here with like a bunch of different lever points. And one way that you could do that that's simplistic but tempting is to say, well, look, a whole bunch of the concerns that you raised are far off future or moderate to distant future concerns for people who have a long life to live. And this guy's got a really terrible prognosis. His pain is so severe. And so basically like all of the benefits get ramped up and all of the risks get ramped down. And so you say, look, it's actually just perverse in this case to care very much. And the reason that I didn't even give that setup at the beginning, although it's one way you could tweak with the lever, is precisely because some of the things that were said in the panel, but especially going towards the end there, it's not at all clear that ending your life in the last 4 months in the midst of, you know, completely uncontrolled, chaotic drug use, especially if you've been fighting it for a long time, right? There are lots of different models of addiction. There are lots of different, it's a really heterogeneous condition. We don't know much about what this guy thinks about his drug use, but if he's someone who's been actively trying to control this, he's been fighting it, for whom it's been pulling him down, it's not actually clear that we're taking seriously all of the right risks and benefits if we load the scale up that way. And so there is a patient that I could construct for whom I think that argument actually goes through pretty well, right? But it's not, I don't think it's generalizable, because the way that scale ends up shaking out has got to be incredibly contextualized to every particular patient and what they value and what's good and how the different treatments are affecting them.
It's highly individualized for each patient. There's no patient who's the same as another patient.
That's what I was going to say, Lauren. And as an ex-hospice nurse, I dealt with this several times too. And it's not that we shouldn't care. It doesn't matter anymore. It does matter a whole lot. And this speaks a lot to what Carla was saying. There's a lot of work to be done at end of life, and to just keep giving someone opioids to deal with their pain, their physical pain, existential pain, emotional pain. I think what needs to be teased out from clinicians is, what are we treating? What is the physical pain? And are we treating chemical, or are we just helping them chemically cope? And it's hard to tease out, but I think it's very much worth the effort to try to tease out and give the proper medications for other things that are causing suffering other than pain.
And some other members on the panel already know my style, and I tend to have certain strong opinions, but I think it's lazy and question begging. I do a lot of work with people with chronic pain who are going to live 20 and 30 and 40 and 50 years with pain. And I spend a lot of time talking to them about pain isn't the only thing in life, right? And so if you walk in the door with a patient and say, the only thing that matters about you is your pain, you missed something. There's a lot of conversation to be having. And so I think sort of dismissing our responsibility to find out what matters to a person in their own life and deciding it's got to be pain, so that's what we manage, really misses a lot. It misses a lot.
Lauren, I'm also just curious, if I don't mean to keep it, I know we have other questions, but this paper, was it referencing or giving an opinion on folks who did not currently have an opioid use disorder, and we were worried we would create one in somebody at the end of life because of the risk of doing that with an opioid? Or was this a paper reflecting on people with opioid use disorder who then they gave this? I'm just curious the frame of reference for that.
It was on opioid addiction and misuse in adult and adolescent patients with cancer. So these were patients who already had, they already had opioid misuse.
Okay, then I think that's the conversation you've already had. It's interesting to pose. I've certainly had folks, and I'm sure others have too, who do not have a history, which is true for like any side effect, right? That people are worried about having a new problem because they're starting to take a medication. And I think that's its own separate conversation.
Thank you. So we do have a question from the group. We have a question from Hillary. She's asking to know more about how Prognosis would affect your planning, I think, in terms of pain management and the plan going forward. So I'm going to turn this question over to Julie and Carla to talk about. Maybe Carla first.
Well, it makes a huge difference because some of the things that I'm worried about for this patient are what are his support structures and stability. If he were to have hospice care, for example, some of those things could be addressed through the support of a hospice team. It's not that hospice is the magic answer to all of these things, but helping him with his medications, making sure that his symptoms are managed, and potentially, depending on the level of hospice he needed, he might even have residential hospice versus inpatient hospice. So this intersects quite a bit with Prognosis.
I totally agree. One of the ways it potentially changes things for me is the level of support I might be able to have at home, or to Carla's point, whether the hospice is basically the home by being a residential house. And a lot of my concerns before, which is, well, how do I make sure he can take these? And how do I make sure he's able to get these medications if I'm deciding to offer them. And the whole problem with discharging him on opioids in the first place, one of the major concerns was that he wasn't showing up to appointments, versus hospice care can go to the house, or if he, again, does not have one, we might have some options to get him some housing as a part of this. So I think just the opening up of supports as one of the main positive features is what maybe opens up some options for us in some of the other management.
And if I can add, hospice is used to, they have these situations in their care all of the time too. And so hospice approaches not just the person, but their, you know, whoever is in their life, their family support system, is they're treating them as well in terms of support. So, you know, there are all kinds of strategies they use to help a person who has this vulnerability with garnering other types of connections and supports.
And I'm just curious, Pat, your opinion on, you know, knowing this prognosis as well. We didn't get into it, but there are like two main medications for the treatment of opioid use disorder, one of which is, well, they both have some limitations in terms of logistics of getting those. I'm just curious your thoughts on the complexities of like methadone and going to a methadone program in somebody like this, and how that kind of plays into the treatment for the addiction side of things.
Yeah, well, I think a lot might, with the methadone maintenance, I think a lot might depend on how debilitated he is. You know, it'll depend a lot on his medical condition. You know, the way methadone is provided at methadone maintenance programs is not the way we would do it for pain management. It's pretty much always once a day. And, you know, like all opioids, the effect on pain is way shorter than you would think from the half-life. So I really doubt that methadone maintenance in and of itself is going to be great. And the medication itself also, you know, part of what it does really is it helps people not use and get into treatment as well. So it helps them to learn how to modify where they are, who they're around, and so forth. And so it's a way to keep the drive off while the behavior change happens. So I'm not sure that, you know, enrolling him in a methadone maintenance program would be any different than prescribing a methadone outpatient. But it's also still a full agonist opioid. He'll get tolerant to that. And if he really wants to use something or sell it, then he can do that. Buprenorphine, you know, there's more ways to get it, and it can work for pain. But it's a partial agonist. It has a ceiling effect. I think we underestimate how good it can be for pain. But it also sure complicates things if you need to intensify treatment with opioids. One thing that's missing from this is I don't know what his dose is right now. So, you know, if he's already on like 600 oral morphine equivalents, good luck trying to get him onto buprenorphine. So there's a lot of nuances that go into it, but it's also true that, you know, the medicines are one part of a complete treatment plan. Like anything else, it's the patient's choice to take them. It's the patient's choice. You know, it's not going to do anything for his cocaine cravings. And so we need to know a lot more about this fellow and his approach to his addiction and treatment than which medicine to prescribe. But which medicine to prescribe might turn out to be an important thing.
Thanks so much. I want to shift the discussion a little bit now to address a comment from Dr. Yoram Ungaru, one of the pediatric oncologists up at Sinai Hospital. Yoram says, please address the notion of cancer exceptionalism as it relates to pain management. There seems to be a willingness to more readily and aggressively treat patients with cancer who have pain compared to some other patients with diseases like sickle cell anemia. And Pat, given your expertise with sickle cell, I'm going to direct this question to you.
Oh God, you're just trying to get me in trouble, aren't you? So I should say I'm no kind of oncologist. I don't generally deal with folks with cancer except in the most like peripheral sort of way. So I don't know if I'm the right person to answer this question in full. What I will say is I think there is a case to be made for it. And, you know, for example, when we're talking about people with sickle cell disease, you know, particularly with adults with sickle cell disease, it really is a chronic pain disorder. And, you know, when you talk about chronic pain, the idea that, you can find the right type and dose of opioid to adequately manage chronic pain, I think honestly is often a myth. I mean, even in our clinical trials, the number needed to treat to get clinically significant pain improvement is usually like 3, which I take to mean that even at 6 weeks, it fails 2 times out of 3, right? So I don't think that the idea that aggressive treatment is opioids and, you just keep going after that until you find the right dose actually works. That said, I think if someone has a life-limiting illness, opioids actually are effective. And if tolerance is the problem, the idea of what to do with that tolerance if they're only going to be around for another 2 or 3 months is not nearly as much of a problem. And so I think prognosis does matter. And also, I think you can do great harm when you're dealing with people who do not have a life-limiting illness, with the idea that you can sort of chase an ineffective treatment to the end of the earth and have it turn into an effective treatment, because I think we get into trouble that way.
I'll just add, I think it's also on this point of cancer side of things. It's really interesting to point out that a lot of our guidelines, right, the CDC guidelines that came out in 2006 specifically excluded patients with active cancer and palliative care patients. I think part of that maybe was the evidence base that they were working with at the time. But I agree and don't, have certainly advocated that doesn't mean that, cancer patients should have no thought to the risks or doing any kind of risk management around their care. And there's certainly growing evidence to support that. There's now like cancer survivorship guidelines through ASCO that talk about pain management and doing this kind of risk assessment in folks who are on a more curative path or have now been cured of cancer but are continuing to have chronic pain, to kind of think about that mindset more. So I think that's growing because that shift has been, I think, important and recognized.
Lauren, is it okay if I jump in for 1 second?
Yeah.
Yeah. So Yoram and I have talked about this a couple of times before, but he jumped back in the chat and said, assume that the cancer will be cured. And I think that's really important. And it goes to part of what Pat was saying at the end. I similarly am not so worried about a problem of cancer exceptionalism in this patient. And so here again, the prognosis changes the weights on the scale, right? I'm not particularly worried about creating new problems that are lifelong if life is 3 to 6 months. What makes me most concerned about this sort of idea that cancer is different, and it goes to what Julie was talking about, the CDC guidelines carved out cancer and end of life together because that's kind of how they grew up, right? Cancer pain was end of life pain. It was active dying pain. And now we have so many cancers that we can cure that will go in remission for years or decades. And so I have a lot of these conversations with patients and physicians about creating new lifelong problems by really recklessly prescribing opioids. And recklessly doesn't mean over prescribing in terms of number, right? They might be prescribing exactly what the patient needs in a moment of really acute, severe pain crisis, but not taking into account that this patient will hopefully live for another 50 years and they'll hopefully be in remission in a few months. And when they are, they need to have a plan. Someone needs to know how to land the plane, right? Someone needs to know what to do with them at the end. So I think this problem of cancer exceptionalism, as Yoram was calling it, is super important for oncology in general, but I am less worried about it in the particular case of, 3 to 6 months to live.
Thanks, Travis. I want to move on now to a question from Dr. Mark Hughes. There was mention that the patient's substance use entails he is making bad decisions. Is this an issue of respect for autonomy? Is his autonomy compromised by virtue of his addiction? And I'm going to start by posing this to Travis.
We're about to take a drink. Yeah, so I saw that Pat was about to jump in too, and he was the one who brought up the autonomy point. This is a place where we might differ, but only at the highest levels. I'm very interested in this idea that I said before, that addiction is radically heterogeneous. And I'm borrowing this from one of our colleagues here at Hopkins, Hannah Pickard, who's a philosopher who does models of addiction. And one of the things that I think is super important is that not all addiction patients look alike. And some of them do seem to present and tell you and believe and look like from the outside as if their autonomy is being constantly attacked, which is to say that their description of their symptoms is something like a lack of ability to do otherwise, like I just couldn't stop myself from using and it's derailing my life. When that sort of symptom is presenting, it makes a really strong case for the sort of thing that Pat was saying, that we might not always do best by a patient by giving them, the drug that they're craving, but might not at the highest level want. If it increases their suffering while decreasing their pain, right? But that's not the only model of addiction. And so one of the recent papers that Hannah published was on a kind of self-identity model of addiction, where for some people, I am an addict, which is out of vogue. We don't typically call other people addicts, but saying first personally, I am an addict is a kind of self-identification against which one is not rebelling. And it creates a sort of integrity and community. And, kind of very flippant way of saying this is someone like this just loves drugs and doesn't actually see the sort of things that we see as consequences as particularly bad. To us, they overweight the benefits and underweight the consequences, right? And so if our patient was somebody like this, this is one of the reasons we need to know their values, right? Because to me, it actually changes the way that I think it's responsible to treat them. They're like having a pretty deliberative approach to what they want, basically at the end of their life, which is they want to be out of pain and they want to be out of all sorts of suffering. And they don't see the cost that we would see as associated with, say, chaotic drug use as all that costly, right? And that's all stuff that as a philosopher, I think we get to subjectively weight and subjectively value. But these are all really different models of addiction. And so that's one thing that I think we got to keep. I actually don't know how this guy presented, because that's not the sort of thing, you don't give a philosophical a diagnosis in a case study, right? But I would be interested to know of him how he sees his use disorder, right? Does it assault him, or is it something he actually kind of embraces at this point in his life?
And to take accountability for what I said, that's not quite what I said. I didn't say that people with addictions make bad decisions. What I said is that I think you can validly consider addiction to be a disorder of the will, because it's about making choices. And, it's about making choices that probably if someone, 5 years before the onset of the addiction said, I really would like to be, doing these things in 20 years, they probably wouldn't be making those choices. But over the course of steadily and slowly being shaped by this supraphysiologic behavioral reinforcer, attention gets biased towards the drugs, craving develops, habits develop, force of habit and the Premack principles start operating. So it is not that every single decision made by everyone who meets criteria for substance use disorder is going to be distorted and bad. But, and so I don't think you can, by any stretch, slap aside the autonomy of someone with a substance use disorder, right? That is not what I said or what I meant. But if you're talking about, here's a situation when you have someone who's actively using substances, they have an addiction, and presented to them as an opportunity to take an opioid, probably neither you nor they, if they're self-aware, can trust their judgment on that one. And when you talk to people who, I'm massively generalizing, but if you talk to people who are advanced in their recovery, that is the way they tend to talk. So going to Travis's point, there's various layers of evidence on the addict identity. One of them being, I am an addict, and therefore the way I think about this stuff may not be right, and I've got to watch myself particularly closely, watch my environment, watch what's reaching out to push the play button on that behavioral program. And then there's I'm an addict, I'm good for nothing, I'm always going to do this, and I'm going to die this way. And I spend a whole lot of time trying to teach people not to do that. But I do think that as basic realism, when you have someone who has this motive to use an opioid, you can't necessarily be sure that they're only using it for some other reason. And probably if they're self-aware, neither can they.
I want to thank everyone for participating today and for giving your perspectives. I think this was a really great, robust discussion. I know I learned a lot. I think a lot of people in the audience learned a lot. So I'm going to turn it over now to Mark Hughes.
Yeah, I also want to thank everyone. A really great discussion. And we didn't get to all of the questions. So when we do a summary that we post on the Berman website, we can also try to address some of those other questions. But really want to thank all of the panelists. Also want to remind folks that on the second and fourth Tuesdays of every month, we have moral resilience rounds. So this is an opportunity for clinicians from across Johns Hopkins Medicine to come together as a supportive community. We're, living in turbulent times. So just having a place where you can come and share your experiences with colleagues, we offer that opportunity for you all. So to keep that in mind and check your emails for announcements about that. Thank you all very much, and we'll see you next month.